This lecture, we will introduce what central line associated bloodstream infections are. We will discuss staff's efforts to reduce infection prevention measures on CLABSI numbers, and also talk about ways that we can engage our patient in really helping us with these infection control measures by having best line utilization, cleaning, not messing with it, to reduce their chances of ending up with an infection. If you're new here, my name is Dr. Kayla Rush. I am an infection prevention practitioner that is certified in infection control, certified public health professional, and healthcare accreditation. I also have my PhD in epidemiology with specific focus on training and orientation practices for infection prevention practitioners. Like previous lectures, or if you're new here, this lecture is recorded and the slides will become available to you within a week or so. They will be emailed out to you along with the link to today's recording. We ask that all questions remain until the end of the session. You can message them in the chat. Like last year's, the 200 series, now in the 300 series, which this year is, we're following the same modality. We're going to have a lecture, the first 35 to 45 minutes, and then we will go into a learning activity or case study example with our real life implementation for these measures that we're talking about. So thank you again for joining us, and we will start our lecture. So first, before we dive into today's material, I just want to briefly tell you what the Texas Epidemic Public Health Institute, or TEPI, is. We are a state organization that is housed at UT Health Houston School of Public Health in Houston, Texas. And our mission is to really keep Texans safe and help build a stronger economy by increasing with our capacity and resilience for Texas communities to respond to future infectious disease outbreaks. We like to try to establish support to our public health workers, specifically our local public health professionals and our infection preventionists, which this series targets towards, that we can have a more robust education to handling these infectious disease that produces less strain on our healthcare systems and promoting our strong economy. So today's learning objectives are to describe central line associated bloodstream infections, or CLABSIs. We're going to discuss CLABSI prevention measures that staff can take to reduce these infections from happening. And then lastly, describe and discuss patient engagement efforts in prevention. This lecture has been approved for a continuing education hour, or an IPU, for anyone that holds an APIC, the Associate Infection Prevention Certificate, and the Certified Infection Preventionist, the CIC. This has also been approved for a continuing education hour for anyone that is a certified public health professional. And instructions on how to complete and obtain your CE certificate will be at the end of the lecture. And again, these slides will be available to you in about a week. They will be mailed out along with the recording for today's presentation. So let's start talking about central line associated bloodstream infections. So basic terminology that you're going to hear today is talking about the National Healthcare Safety Network, or NHSN, bloodstream infections, central lines, and central line associated bloodstream infections. So the National Healthcare Safety Network is an organization that lies within the CDC that determines epidemiology definitions of what healthcare acquired infections are. And currently in the United States, about 1 in every 31 patients on an acute care inpatient, about 1 in 43 patients that are in nursing homes will develop at least one infection associated event with their healthcare treatment or stay. So that's a lot of individuals. Every year, NHSN produces a report of looking at tracking and trending our HAIs over the time. When we were developing this presentation, we had information from the 2023 year, 2024. Last year was still being compilated. But overall, from the year of 2022 to 2023, we did see a nationwide reduction in central line associated events, which is really great because these are very, very serious events. People that develop these bloodstream infections, they can become septic. They can be affected with their length of stay, antibiotic administration, and on the severe case, it can lead to mortality and death of these patients. So every year, the National Healthcare Safety Network comes out with a patient care safety manual. It is updated annually. This is the one that just got put out last month in January 25. Every year, it's about the same. You can get a synopsis of edits each year. Sorry?
We can't see the slides.
You can't see the slides. Okay. What about now? Can you see them?
I do not.
No. Kayla, this is Janelle. Maybe try stop sharing and then reshare.
Okay. How about now?
I see an NHSN manual slide.
Okay, great. I'll back up so that we can see. Okay. So here's just a quick review of what I was just talking about, just some definitions that we were going to talk about today. And basically our National Healthcare Safety Network, or NHSN, it is our national monitoring system that we use here in the United States. It's a part of the CDC. There is an annual requirement every month that you are reporting your HAIs to this institute within the CDC to help track and trend. And every year they come out with a composite report how we are doing. When I was developing this lecture, the data from 2023 was available. 2024 was still being analyzed. Sometimes there's a lag in that it doesn't come out until about mid-year of the following year to see how we are doing with our HAIs. And with this specific HAI, this central line associated bloodstream infection, over the last 2 years, from 2022 to 2023, there was a 13% reduction nationwide. So we are trending in the right way, but there's still work to be done in this area, especially that we're still seeing these types of infections. So as I was saying, every year the manual comes out. It is free. You can go online, Google NHSN Manual 2025 and download your free copy. There is a synopsis that comes out of saying what the different changes from the previous year to come. This is the infection preventionist, epidemiology, healthcare acquired events, HAIs, tried and true definitions. This is how we report things. This is how that we build our policies, our procedures, our protocols around. So knowing these definitions inside and out is really crucial to being an effective infection prevention practitioner, and really kind of honing into that safety event for our patients and providing best care for them. So just previously, there was a national benchmark done in 2015 that specifically kind of started this reporting process. And compared to that, it has a breakdown of acute care hospitals and inpatient, and then our long-term care. So kind of our three main areas. And then there's also a different NHSN manual that specifically works with nursing home definition. So that's in a different category with a different manual. So if you are part of a nursing home facility, make sure that you're using that manual, not the acute care inpatient manual. The epi definitions are different with your different infection workups. So be very mindful that you have the right manual and you're doing your definitions. But looking at our differences, we are performing better, which the metric from the 2023 to 2022 to 2023 indicated that there was a 13% reduction. We are seeing nationwide that in our states, there was 44 states performed better than the previous national benchmark that was conducted in 2015. 9 states for our inpatient rehab facilities, our IFRs, and then our long-term care. There was only 1 state that was doing lower in our acute care hospitals and our long-term care hospitals. So that's great that overall nationwide we are improving in these metrics. So we're going to do a brief workup of how we kind of do our healthcare associated infections. We're going to talk about the date of the event, or DOE, the infection period window, our IWP, our location of attribution, our LOA, and then look at our CLABSI criteria. I did a previous lecture titled 105 Introduction to NHSN that goes very more in depth in these definitions. So this is kind of just a quick review of that. And then we're going to go into a case study of how to really take action and implement some of these ways to reduce HAIs, specifically a central line associated bloodstream infection. So the first thing that we want to do is determine our date of event. So this date of event will be the first element to use to meet the criteria, and it will be into 2 buckets, either HAI, which is healthcare acquired infection, or POA, which is present on admission. POA means, long and short, that the individual already had this infection before they came into the hospital. So something that they developed in the community, or if you see CO, community onset, that's another way to say that this infection was induced before they came into the healthcare facility. This date of where it is will kind of determine if it is a hospital onset or community onset, and kind of take actions. If the first date of event is within that POA window, you're in the clear. You don't need to do further HAI workup on it. You'll look at how to determine your date of event by looking at the time frame, if it's in the first day or 2 of hospitalization. So if they're having clinical signs and symptoms or a diagnostic test on the day of admission or the day after admission, that's considered POA. And NHSN uses the calendar day, not X amount of hours in admission. So if you get admitted at a 11:59 p.m., that is technically day 1, even though that is 1 day. Okay. 1 day on of admission. So be very mindful about that. And I know some of our clinical folks, especially our providers, they go on X amount of hours since been admitted. It's been 1 hour, 2 hours, 24 hours. You need to remind them that NHSN uses calendar date, not X amount of time from admission. This date of event will also be used to determine your infection time frame, and then also your repeat infection time frame. And we'll talk about those next. Okay, so the next thing is determining our infection period window. And this is set by the first test or procedure or exam of localized sign of infection. So you can either have a diagnostic test or a sign and symptom, and that is your day 1, and then your infection period window you do 3 days before and 3 days after. So it's a 7-day period criteria that sets your infection period window. And this applies to your CLABSIs, your central line associated bloodstream infections, or your CAUTIs, your catheterized urinary tract infections. And I'll show an example in a minute. This criteria does not necessarily mean a diagnostic test. So some people, when they're looking at it, they specifically look at an imaging or a lab or a vital sign. It can also be based on symptomology of different criteria. So definitely looking at those clinical labs and those clinical diagnostic tests, but you also need to be reviewing your patient care notes, your admitting notes, your ER triage notes, because that could be the first sign and symptom of this infection. And when you have multiple criteria met, you always want to use the first one with the earliest date of the event to be used first. And I'll show you an example. So here is an example, and this directly comes out of the NHSN manual, that looking at your present on admission, your infection period day window, and then your healthcare acquired infections. And you can see those on the left-hand side. The correct option is using your different diagnostic tests, but with our proper onset. So when you look at option 1, you see that new onset cough, that's on day 2. And the minus days are days before admission. So your minus day 1 is 1 day prior to hospitalization looking back, and your minus day 2 are 2 days back looking out of hospitalization. Day 1 is on first day of hospitalization, and then day 2, second day of hospitalization, day 3, etc. So right here on option 1, which NHSN deems as the correct way to work this up, is that we have our first a cough, and then on which happens on day 2, which would be present on admission from that criteria that we just talked about. And then day 3, there is an imaging test that has an infiltrate on it. And day 4 with fever over the fever level of 38.0 Celsius, which is 100.4, so 100.4 Fahrenheit or above. That is the temperature that NHSN use as definition as a temperature. If you see in any type of charting notes, if it says temperature, fever, you need to go look at their vital signs and specifically look at the number. If it's below 38.0 Celsius or 100.4, it does not meet the NHSN definition for fever. And then on the 6th day, they have a blood culture, and 7 days, more rattles from breathing, they have fever, they have cough, rattles, etc. So here on number 1, we have present on admission. This patient came in with these symptoms, and we did the diagnostic test, so that this is really saying that they had it in the community, most likely why they're seeking treatment. Option 2 is the incorrect way to look at this. This is that we disregard that new onset of cough. So on day 2, we don't see that as the first clinical symptom of infection, but we're using day 3, which is now in that healthcare acquired infection day of that imaging test, and then you're working it up. So this is when you're not doing it correctly, you can oversay you have healthcare acquired infections at this rate when really it's POA, and vice versa. So it's really important to do a thorough review to make sure that you are looking for the first new clinical onset. With this example that they say new onset of cough, if your patient has COPD, any type of respiratory asthma, onset of cough is not a new diagnosis. So make sure that you look at exactly what is being said and then working it up that way, because that will kind of put them on in a different bucket if this is more of a chronic versus infectious, and then looking at the definition. So the next thing with setting your DOE or your date of event, that will set your 14-day window of that specific infection. And that means that within that 14 days, from NHSN definitions, we cannot have the same type of infection occur within that 14 period day window. So here's the example that we're on day 4 of the hospitalization. We're having a urinary culture of over 100,000 with a fever, and that is being used to meet our catheter-associated UTI or a CAUTI event. We have a repeat culture later on day 9, which would kind of show that, you know, maybe there's another UTI. No, it's really just showing that within that 14 days, once you set your window, you cannot have a repeat infection of that same category. You could have a UTI and then maybe a secondary infection there is urosepsis. So if you have it in the urine, they can become septic and into the blood. So making sure that you're looking at kind of what is occurring in different workup. I mean, you could have a UTI and then also meet the pneumonia definition as well during that same 14-day window, or might have a surgical site infection or an SSI, a C. diff, and MRSA. So with this 14-day repeat time frame, you cannot have the same type of infection within that 14-day window period. And then lastly, then we look at location of attribution. So your LOA is always going to be the location that the infection occurred when you're reporting that. So you're looking at where that patient is listed, on what floor, what unit on that inpatient location. EDs do not count, they're outpatient. This is specifically for inpatient locations. And then if you, like many facilities, if you have a patient moving around between units, different departments, they're in ICU, then they're in step down, then they're in med surg, then they're going to surgery, you always want to look at your transfer rule of knowing that it is the date of the event, the day before where the patient was. So you want to go back a day to see where they were before, on the start of the day before the infection. So that kind of gives you a little background of how we first do our definitions. And then now we're going to go into what specifically is a central line associated bloodstream infection. So central lines are intravascular catheters that really help give us drugs during a time where we're needing certain types of medication. We can have these intravascular catheters in many different locations in our body, providing care. Here are the locations that NHSN looks at specifically in our adult patients too. If you have an infant, you can use an umbilicus under your infant or peds definitions, but these are the ones for adults. And here's just kind of pictures of what these infections look like. There you can see the central line going in underneath the skin. There's redness around, there can be oozing, there can be draining, but it's very easy to see when a central line has been infected, especially around the site. So here's just some examples. So our eligible central lines are there for more than 2 consecutive days. So on day 3 and following, they are eligible to meet the healthcare associated event, central line associated event on that current admission. That central line though needs to be accessed. That is part of the definition. So if it's just there, if a patient comes in with a central line or more likely a portacath, it needs to be accessed. That starts our day 1. So with our ports, they are in our patients no matter what, if we're using them or not. Their clock starts when you first access the port. So if that patient's there for 5 days and you have not accessed that port, day 1 starts on the first day of access, and then day 2 and day 3 going forward. So not necessarily on admission. So be mindful of that, and always double check your documentation to see when the actual port is accessed. That can be sometimes kind of tricky. Some people will misdocument that it's being accessed, not accessed. So if you're doing portacath workup, definitely confirm that the port was accessed on XYZ. You can have permanent lines, you can have temporary lines. NHSN uses both in their definitions. And then we have our primary bloodstream infections, or a BSI, or we have a secondary BSI. Basically, the primary bloodstream infection is an infection that has caused with no other secondary source or any other bodily site. So with all the investigations, our diagnostic tools, there is no other site of infection that the bacteria or pathogen could have migrated into the bloodstream to cause this, compared to a secondary bloodstream infection is that it's a secondary site. You might have had a surgical procedure. They might have had pneumonia. They could have had a UTI. They could have had a wound. They could have had a pressure ulcer that became infected, and then now the bacteria is in their bloodstream. So that's the difference between a primary and a secondary. So for meeting our central line associated criteria or our CLABSI criteria, you need a central line from the list that I provided for more than 2 consecutive days that have been accessed in an inpatient location. So if they're still on day 2 of admission in the ED, their clock doesn't start until they're on an inpatient location unit to start the time. You need an eligible organism that meets this criteria. There's a whole spreadsheet of different organisms. If you're never not sure, or when you are working these up and you're not sure if this meets criteria, if there's an exception, you can always email NHSN and ask, and their email is right here. They're really great about getting back to you. I've emailed them myself directly about cases that I've been worked up if I had not had the opportunity to talk with another infection preventionist of, hey, I think this meets definition. What is your take? Can you do a review? They're always a great resource to use. And then specifically using a laboratory confirmed bloodstream infection with an eligible organism, and then an eligible central line to be meeting that. So you need a central line that has been in place and accessed in an inpatient location for more than 2 calendar days, and then a eligible organism, and then determining that it's a primary source of infection, not a secondary, that there's no other cause of having this bacteria within the bloodstream. So looking at specific definitions, you can have there's a couple different specific criteria, but you're looking at patients of any age which have one of the signs and symptoms of following, so they can have fever, chills, hypotension, and an organism not related to any other infection, and 2, the same NHSN common commensal identified from 2 or more cultures. So this always comes up with, is there a potential cross-contamination due to poor cleaning of the skin for blood cultures? So if you have, with this definition, you need 2 of your blood tubes to have that same organism. If just one has, it does not meet definition. And you can look at it as cross-contamination. If you're still unsure if that's a true infection or not, you can always redraw cultures to see if that organism is within 2 or more blood cultures. So now that we know what central line associated bloodstream infections are, what the definitions are, what are some ways that we can help prevent them? These are infections, pathogens that get into our patients in healthcare settings, and they have a positive blood infection. The number one way for prevention is always hand hygiene and clean hands. For any healthcare associated infection prevention best practices, the number one thing and the easiest thing that you can do is have a really good hand hygiene culture of making sure that there is positive reinforcement. Everyone takes accountability of washing their hands appropriately and effectively. The next is using aseptic technique. So that is maintained aseptic technique when you are inserting a central line, when you're conducting central line changes, or any type of catheter manipulation. So when you're pressing fluids, giving drugs through that central line, that you're scrubbing the hub, that you are aware of aseptic field, and that you are not accidentally transmitting anything into that line due to aseptic technique breakdown. So a good way is always using sterile gloves, drapes, skin prep. You know what your field looks like, you know how you're going to move, that nothing's hanging over when you're wearing your gown, that it is properly tied. It's not tied in the front and hanging over the patient, and that you're potentially indirectly putting other pathogens within that field because your ties from your bow are now in the surgical field. The next is having proper barrier precautions when doing this, so we know what to wear. We're wearing our proper PPE. We're conducting hand hygiene as step one, always before we put any gowns on, and that we are properly covering our patient and our sterile site so that we know how we're doing, what we're doing in hand hygiene before that we do any type of line manipulation from dressing change, cleaning, or pushing drugs, fluids. Next, our catheter site care and maintenance, so making sure that we are assessing our catheter sites for any signs of infections, like those pictures that I had previously showed for wetness, swelling, discharge, checking our vitals, asking our patients, how does your site feel? Is there any hot? Does it feel hot? Do you have any changes? Is there any smells? Anything like that? And a good way to do that is always clean with aseptic products such as our chlorhexidine, making sure that the dressing stays clean, dry, and intact, and is getting changed every 7 days or more if it's soiled. Every organization can have a different protocol on changing your dressing. If you do it every Sunday, every couple days, who does it? There is some variation between facilities, but whatever your policy and procedure is, that it is ingrained to your staff of knowing how to document that they have looked at the dressing change, they're aware of the dressing change, the dressing is not falling off, it's not sliding down. All of that is really, really important to making sure that the catheter site stays clean and not cross-contaminated. Before insertion, using the proper skin prep, and that we are skin prepping appropriately and letting enough time to hit the skin before we put in the central line. So making sure that you're using a product such as chlorhexidine to reduce your CLABSI risk when you're first inserting your central line. And then that you're using good central line utilization. So you're really assessing, does this patient need a central line? Okay, yes, they do, based on how critical they are, what drugs they're getting, and then also that you are currently assessing, is there an opportunity to downgrade the central line to a peripheral or to a peripheral IV. That should be discussed every single day for any patient with a central line to make sure that as soon as there is an opportunity to remove that invasive device, that we are taking that to prevent central line associated bloodstream infections. Which goes into proper removal of our unnecessary lines. So as soon as it's not needed, pull it out. And making sure that, we're thinking long-term, if this patient is gonna need a line for very long, do they need a line? Do they need a graft? If they're on dialysis, is this gonna be permanent? Are they a candidate for an AV fistula? Kind of looking at the short-term, medium, and long-term range of what this line is gonna be used for, how long do we think it's gonna be needed, and having those conversations early can really help making sure that we're having good utilization for our lines and we're removing them as soon as we don't need them. There are multiple products that have antimicrobials impregnated in the catheters. Those have shown clinical-based evidence to reduce the risk of your central line associated infections. Having these products are great. If you are not in your product committee and product evaluation committee, I implore you to definitely go see if you can sit in those committees. You should be looking at the products that are coming into your facility and evaluating them, asking the vendor for these certain things. Do you have evidence showing that it's been effective against reducing this? Is it impregnated? What are your sensitivity and specificities for the data that you've run? They should have done validation studies before that product has come into your facility. It's completely within your scope of practice to ask them for these things, discuss with your committee before you allow that. Having a very comprehensive overview of a product before it gets into your facility will really help you on the back end with Joint Commission and CMS products during audits, and then also with your infection risk, knowing how to clean it, how to maintain it, what the risks are, any recalls that have occurred on it that can help you knowing the background before that product hits your facility. And then conducting surveillance. Earlier detection is always the better, making sure that you are looking at your central line utilization, you're rounding on patients that have central lines that are high risk for CLABSI events. It is really important that we are doing early surveillance to really understand what's going on in our facility to help prevent these types of infections. And then lastly, staff education and training, having good policies and procedures ingrained to staff are always great about the infection prevention risk, best practices and procedures and aseptic techniques with our donning and doffing, how to assess lines and maintaining sterile field. That's very critical. So making sure that you are talking to staff about this, you're observing, you're auditing, you're doing, when new staff is coming on, they're doing their clinical checklist and that they have become competent and all these things before they are off orientation is always really important. As I mentioned before with our ports are they are a permanent catheter that these individuals have. They get accessed very differently than other types of lines. So making sure that whoever's accessing your port is properly trained, they feel comfortable and confident in accessing it, and they know how to prevent cross-contamination. And then lastly, keeping the line closed, proper dressing, you're scrubbing the hub, you're putting the cap on it, making sure that there's no way that it's just left open, that any type of pathogen can gain entry into that system. So that's all ways that staff can prevent central line associated infections. And now we're going to go into how can we get more engagement from our patients in helping us prevent these types of infections. And the first thing that we can do as providers and ancillary staff is to really help educate our patients and their families what a central line is. Talk to them about the why. What's the purpose about this line? Why is it needed? What does it do? And be transparent with the risks of infection, that they need it for medication administration for X, Y, and Z. However, there is a risk of infection with this. And then talking about the importance of 3, the prevention. Because of these risks, we ask that you do not manipulate your line. Try to keep your hands off your line. If you notice your dressing is coming undone and it's not adhering to your skin, that the patient feels comfortable to speak up and tell their clinician, their bedside nurse, or their physician that, you know, my dressing is starting to come off, or it itches, or I feel it flaking, or, you know, I feel some hotness underneath of it, or I've noticed a smell, making sure that, you know, they're a part of it and that they also know what the care looks like. So that kind of goes into our participation of care. So talking about what the goals are for your central line, telling them kind of how long the plan is to have them as soon as that they're downgraded on medication or switch them from IV or PO. You know, we plan on removing it, that that someone should be rounding on their central line, or during patient focused rounding that we are asking them about their line, and that they're invited to participate in infection prevention measures, which is hand hygiene, always reminding our patients to wash their hands effectively with soap and water or an alcohol-based cleaner, that they need to have CHG bathing for their lines. I know some patients do not like the CHG. It can leave them sticky and they will complain of feeling sticky. The stickiness is the aseptic adhering to their skin to prevent other pathogens. So kind of telling them that, yes, you might feel a little bit sticky, but that's the purpose of this, to prevent other pathogens from invading their skin. And that kind of stickiness kind of creates a barrier against it. So making sure that you're framing your conversation, you're participating in them, and that leads us into 3, that they're feeling empowered. They know how to help. They are washing their hands. They're also championing and reminding their healthcare providers to wash their hands. They're being compliant with the dressing changes, or if they're noticing that there's something wrong with their dressing, that they're speaking up. They're having baths, regular baths and CHG baths, and then they too are asking about their line removal, that they're speaking up, they're asking about, their clinical care plan of what's going on, what does my treatment look like, and what are next steps that we can take to prevent these infections. And then lastly, other things that you can do in their environment is have feedback mechanisms that can be signs that really help them understand infection prevention practices among healthcare providers. That can be the hand hygiene signs, the CLABSI reduction signs, the donning PPE signs, our visual tools, any posters, brochures, that talk about central line associated or CLABSI prevention at point of care, any education that you can provide them orally or written in their first language is always really helpful to make sure that they're understanding. And if your facility has digital engagement efforts, such as tools or apps that the hospital system can send patients and staff about central line cleaning care protocols, that's another way to get more engagement for compliance from the patient and family side too. So now we're going to go into our next section of the lecture, which is kind of our knowledge check, which is kind of a case example of what would we do and how would we develop a CLABSI reduction plan or situation. So I ask all of you, here's the QR code to go into our learning check. We'll kind of walk through this kind of case study of what we could do, how we develop these things, how we engage patients. It is a short 10-minute or a 10 question learning activity that will go out as a group. I also encourage anyone, there will be questions that will come up, and I ask and I implore anyone to unmute themselves to provide the correct answer. You can also put it in the chat. And we kind of want to make this engagement for participants. So has everyone had a chance to scan the QR code? I'm not hearing no, so I'll start. So our first case study, we have IP David is conducting the fourth quarter review of healthcare associated infections or HAIs, specifically looking at CLABSIs, CODIs, CDIs, and SSIs, and reviewing their annual trend along comparing data from the previous year. So this way we're at the end of quarter four. So this is December or January, December 2024 or January 2025. And we are looking at this past year of how we have performed in our HAIs. And it's always great to look at the previous year to do a comparison to see how you have been trending overall. If things have been consistent, not consistent, if you're trending positive, negative, it's great. Knowing your data can always highlight and shed light on what is going well and opportunities for improvement. So on the bottom left, we have data from our 2024 year, and we have compared to our 2023 year. So we're looking at our CLABSIs, our CODIs, our CDIs, and our SSIs. So you see the difference between the two, that all these metrics as we've gone through the year. So looking at that data, what healthcare associated metric has increased in 2024? Was it our CLABSIs, our CODIs, our CDIs, or our SSIs? And this is where you can unmute yourself and provide the answer. Or put it in the chat. Yes, A. Yes. So IP David noticed a rise in our CLABSIs. So now we're going to break down our data a little bit further so that we can understand what is going on and to see what kind of information does our CLABSI data tell us. So we have in January 1, we had 2 CLABSIs from a femoral line or an intrajugular or an IJ line. In quarter 2, we have 2 IJs and 1 femoral. In quarter 3, we have 2 IGs and a femoral. And then quarter 4, we have a huge spike. Now we're up to 6. So we have a 200% increase from quarter 3 to quarter 4. And we have we have 3 intrajugular line infections. We have 2 femoral and 1 subclavian infection. Okay. So obviously we know that there is a problem. Is this problem specifically from the data that we just looked at, as here's their breakdown, and you can see what units they're associated with. Bad 2A, 3B, 3CC, 4B. Is this problem, as you see where the location of the central line associated infections or the CLABSIs were, when we are developing a reduction plan, what unit do we want to specifically look at? Do we want to do 2A, 3CC, 4B, or all units that have central lines? Who would you involve in your KPI? Yes, that's right. All units that have central lines, especially that this is not a localized unit problem that we got from that data, that different units are having central line associated infections. So this is a hospital-wide problem that we need to address. So after we have identified there is an issue, the first thing that we want to do is circle our own team and discuss it within the infection prevention department, or if your IP sits in quality, first discussing with your specific department, hey, I've identified an issue. I want to start a quality reduction or quality assurance performance improvement plan, a QAPI or a KPI, a key performance indicator, to help reduce these types of infections. So we want to start looking at how do we develop a reduction plan. So when we develop reduction plans from going back to last year's and what we know in the field, when we develop these plans, who do we include in these meetings? Is it all the departments in the organization, such as our central supplies, EVS, surgery, outpatient rehab, inpatient rehab, just the departments that are involved in the process, i.e. departments that have central lines, only our nursing departments, since they're the only ones handling our lines, or only our microbiology department, because they're the ones that have the blood cultures that are positive. So what departments do we want to involve in this KPI project to possibly identify and improve our CLABSIs in our facility? So yes, we would do B, the departments that are involved in the process. So you want to make sure that you include all departments that are involved in the process, and that involves knowing from the front end to the back end of what that department is and what's playing in that process. So when you look at CLABSIs, you want to always include your nursing and your physicians, the individuals that are placing the lines and that are taking care of those lines. You also want to include microbiology, because you want to make sure that these are true positives and that maybe we have a new assay in the lab, maybe our blood contamination rates have gone up, maybe there's new phlebotomists, maybe there is a phlebotomist shortage, the nurses are drawing them. You want to make sure that you understand what's going on with these cultures. And then also central supplies. Has there been a change in our catheters that we're using in the facility? How we are maintaining our dresses, our aseptic technique supplies, our skin prep, exactly. Kind of our whole picture of what goes on into this problem in maintaining our central line. So you want to get leaders from all 4 departments to start discussing that how are you going to resolve and make improvement efforts on this specific situation. So next, IP David is going to collaborate with all departments and explore the following within nursing. Is going to talk about prevention and auditing practices, physicians reviewing justification, microbiology, as I mentioned before, contamination rates, and central supplies, that we have their proper supplies to be able to take care of these central lines during their insertion, maintenance, and removal. So for this question, it's important to understand all components that go into the CLABSI, because is that A, you need to understand the issue before you can develop a comprehensive solution to really affect it. B, infection prevention control issues are complicated. C, one approach is needed. You only need to look at one metric and really focus all your time and energy on that one thing. Or D, it's not needed and a collaborative meeting is a waste of time, which sometimes we unfortunately hear of, but how would you do this? Yes, answer A, you need to understand the issue so you can develop an effective solution. So based on that information, we wanted to have enough information to have the complete picture. And by doing that, when we were talking about with the leaders, what had previously occurred during root cause analysis, which occur after every healthcare associated infection, we found the following: that nursing had an influx of new grads beginning at the facility. So maybe we need some re-education and more support on new nursing, our new nurses. Physicians are forgetting to remove central lines before they move units, not addressing and reviewing medication administration. Central lines, central supplies we're looking at are available of our chlorhexidine wipes, our CHG wipes, and bathing. And then for microbiology, our potential concern for blood contamination rates. So like anything, we always want to use the SMART acronym, the specific, measurable, obtainable, relevant, and timely. And then also making sure that we have effective and efficient and realistic metrics that we want to be doing. So if we come up with a KPI, we want a metric of reduction. So what is a SMART measure of reduction? Would it be 100%? So from going to 6 to 0, a reduction in 30 to 50%, a 10% reduction in CLABSIs, or a 75%? What would be, do you think, an actual obtainable metric? Yes, it would be B, going into a 30 to a 50% reduction. So we had targeting for Q4, we had 6 CLABSIs. If we could get to the end of March with just 3 to 4 CLABSIs, that would be really great to see that type of reduction over that period of time. And some of these, anytime that you do a KPI project or reduction, sometimes it takes a while. So being flexible and knowledgeable of what else is going on in the facility in case you have to change your timeline. If it's a new pathogen, you're at capacity, you have an influx of influenza, there's other things that sometimes will delay our timeframes and then pushing out these initiatives too. So be mindful of that when you're doing KPIs. So as we've talked about, what type of approach is needed? Do we want a single, two-prong, multifaceted, or just we're going to try a million things and see what works? What's the most efficient, effective way to do this? And especially that we've already identified multiple areas of weaknesses. Yes, that C, having a multifaceted approach is the most effective, especially that from our root cause analysis, we are already aware that there is gaps in these 4 main categories in our nursing, physician, central supplies, and microbiology. So next, then you start just going through meeting with each leaders, talking about different initiatives to try to addressing that. With nursing, that you want to do training and education. So you meet with your nurse educators to push out education. You want something quick, easy, simple, not this long drawn out thing. One-page handouts are most effectively. You want to focus your different training if you're doing retraining at the highest risk. So the units that have the most CLABSIs versus the fewest, start with them first and then go through. You want to audit their dressing changes, their bathing practices, and the central line utilization so that our nurses feel empowered to ask for removing or taking that central line out. They're also working with pharmacy of saying, can we switch from IV to PO for our administration of medication. They're completing during their auditing their central line bundles. They're looking at daily inspections of hand hygiene, alcohol, decontamination practices using chlorhexidine with our dressing changes, any signs of infections, has the dressing been changed, assess for readiness of removal with documentation. And this is just an example of one tool that you can use. There's lots of great central line bundles that are out. I have some of them listed in the references section of the slides. That you're also looking at, it's documented that it's necessary, there is no drainage, date, time, last 7 days, it's transparent, all these things, that these should be assessed daily. And then that making sure that you are bathing the patient appropriately. You have your 6 areas, you are following your steps and you're using the product as appropriately. You're not diluting it. If you are not using the CHG wipes, you're in just the solution, you're not diluting it by putting water on it, and that it has the contact time with the skin appropriately based on the product that you are using. Making sure that IFUs, that instructions for use from the manufacturer, that you're being compliant with. And when we're looking at our central lines, we are looking at specifically what of the following based on the information that I just provided you. Are we looking at hand hygiene, daily assessment, catheter site care, or D, all of the above when we're assessing these? Yes, that's D, all of the above. Great. So after we're rolling out with our nursing, then we meet with our physicians. We talk to our CMO, which is the Chief Medical Officer, the physician in charge of all the physicians, of looking at line utilization and placement. And then we specifically want to meet with physician and pharmacy to make sure that we're doing multidisciplinary rounds about drug administration, that we are having those conversations daily, that any chance to change from IV to PO. So this is before after we meet with the CMO, we start building. We found out that through that discussion that physicians, with all the things that they are responsible to do, they are forgetting to assess our central lines, and they're just being left in. They're also maybe there's opportunities for different placement. The different lines have different infection risks. Femoral lines are the highest risk of infection compared to interjugular subclavian. So also, reframing the education with our clinician folks and our providers that anytime you have the opportunity to put in an IJ or subclavian over a femoral line, that is always preferred because it has a reduced infection risk. However, we also know that our critical patients will need femoral lines so that we are assessing and making the best clinical decision in that situation as well. So before physician engagement, we're looking at the type of line utilization. So we're finding 10 femorals, our 25 IJs and 5 subclavian. And then after physician engagement, we're talking about the infection risk. We're providing them with best practices, white papers on these infection risk of how beneficial it is not to have femoral lives. You see a decrease in femoral lines with a slight decrease in IJs and an increase in subclavian. And then after we are building in we've had the discussions with them, we have now put in little reminders in the EMR order sets of what type of lines and making them document justification. You see a drop in your IJs and an increase in subclavians, which we want to do. And then overall, and then lastly, when we're talking with pharmacy and building those relationships, to that we see an overall drop in our line utilization. So after we've done different rollout and different measures, specifically with our physicians, you see the number of central line catheters within the organization, your line utilization has dropped over time from initially going from 40 lines a day to 28 lines a day. So by looking at all of that, what was the most effective way? Did we use a single prong approach or just in physician engagement? a two-prong or a multifaceted or a multi-prong approach. So we looked at physician engagement, EMR, and pharmacy partnership. Yes, see? And then our last step is to talk with our central supplies to look at the vendors, making sure that we have the right CHG, the right kits, the right bathing supplies, and that we're talking with microbiology, looking at and evaluating blood contamination rates at your facility. There might be a breakdown between phlebotomist and nursing or laboratory, and making sure that within the benchmark that the organization has set, that those contamination rates are true and that we're having the right supplies on the floors for our staff to use to properly care. So after all of this, IP David sets up monthly meetings to discuss progress, to talk about the different initiatives, talking about education with nursing, physician engagement, central supplies, and our microbiology benchmark for our contamination rate. And then after that, we see at the top end, after these meetings and after these initiatives have gone live, we see our first quarter, our 2025, we have one CLABSI in January, one in February, and one in March. So then now going into our first quarter of 2025, we only have 3 CLABSIs based on these initiatives. So going from quarter 4 to quarter 1, what type of reduction did we see in the central line going from 6 until 5? Yes. D, 50%. And then lastly, by creating a multifaceted approach, were we able to see an increase in organizational CLABSI prevention increase? So did we see an increase in prevention? Yes, A. So here are the answers. And then lastly, I know we're just at time, central line associated bloodstream infections have significant outcomes for both patients in our organization. And they're a very complicated problem. So making sure that we understand what's going on in our organization, where our low-lying fruit is, and that we understand these very complex problems due to multiple individuals playing a part in patient care, we need to have a multifaceted approach with all these individuals to help reduce CLABSI rates and create a safer environment for our patients and provide them with better care. So I know we're at time. I want to thank you all for attending today's webinar. You can connect with us. Here is our information. I'm now going to open it up for questions. Our next module will be in March, on March 6th, and we'll talk about C. diff infections, what they are, to discuss reduction and prevention efforts, and then also patient engagement activities. And then we ask that anyone attending today's module complete the post-module evaluation survey, which the QR code is right here. This information really helps us develop these modules, get feedback, what you want to hear, what topics you want to hear, how we are doing, and how we can better serve you in the community by knowing what to present and how to present it. Anyone that completes the post-survey evaluation will be entered into win Teffy swag that will be mailed out to you. As I mentioned before, these lectures are recorded. They're placed on our YouTube channel, and then within a week, you will get a link to the slides and today's recording with all this information as well. And those that inquired about CEs, here is the instructions. Just like last year, you need to create a Learning Stream account. You can go, here is the link with the QR code. You want to register for this class. It will then shoot you an email to the learning check and then have you complete the post-survey evaluation and then email you your copy of your certificate. If you have any problems with this, please email us at that IPC email that was listed previously. And thank you all for coming to today's lecture. And now I open up for any questions. Dana, is there any questions in the chat?
None at this time.
Okay. Well, if there's no questions, I just want to thank you again for attending today's lecture, and we look forward to seeing you in March.